Hello and welcome to NAFLD NASH webinar. This is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a patient advocacy 501c3 nonprofit organization representing millions of liver patients in California and beyond. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host patient and physician-centered educational programs. To learn more about our programs as well as our events, please visit our website, liverhealthfoundations.org. Tonight's webinar is about NAFLD and NASH. As you may know, June 9th was the International NASH Day to raise awareness of this disease that has become an epidemic. NASH is a more advanced form of NAFLD, or non-alcoholic fatty liver disease, with serious health consequences. In fact, NASH is a growing global health challenge at this point. The problem is that most people don't know they have NAFLD or NASH until the disease has progressed. I read somewhere that there are an estimated 22 million people in the United States who live with NAFLD and with NASH, and more than 8 million of them have significant liver fibrosis, which will add to the problem and possibly transplantation. While numerous pharmaceutical companies are in the process of developing treatments, there is still no approved NASH medication in the market. The goal of tonight's program is to give our audience a clear understanding of NAFLD and NASH and talk about the ways we can protect our liver from this terrible disease. I want to put the disclaimer in. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare provider. Please consult with them. All right, tonight's we have two sponsors, Global Liver Institute, or GLI, and Madrigal Pharmaceuticals. Thank you to our sponsor. We appreciate your help in supporting us, providing these free educational programs to our audience. It is now my pleasure to introduce Dr. Edward Mena, who has generously accepted to be the presenter and the MC for tonight's program. Dr. Mena is a world-renowned hepatologist and the medical director of the Pasadena Liver Center and director of California Liver Research Institute, or CLRI. After obtaining his undergrad degree at UCLA and medical degree at USC, Dr. Mena completed his residency at White Memorial Medical Center, where he became the chief resident. Following this, he completed his fellowship in hepatology at USC Rancho Los Amigos Medical Center Liver Unit. Dr. Mena has been serving the Los Angeles community for the past 20 years. During this time, he established a multidisciplinary center called the Pasadena Liver Center. In 2007, he and his fellow collaborator provided treatment options for patients with advanced liver disease. As the medical director of the Pasadena Liver Center, Dr. Mena coordinates all aspects of both inpatient and outpatient care. In addition, he has been instrumental in improving the treatment of liver diseases. He established a collaboration with Cedars-Sinai and USC liver transplantation teams that facilitates the management of liver cancer and liver transplant cases. This revolutionary program created an outpatient treatment center for hepatocellular carcinoma patients, bringing together patients and doctors that provided a more efficient process of administering treatment. In 2016, Dr. Mena established a research institute called the California Liver Research Institute, CLRI. CLRI is a nonprofit organization focused on the advancement of treatment and cure of all forms of liver diseases. Since its inception, Dr. Mena has coordinated over 20 clinical trials. Under Dr. Mena's directorship, the Pasadena Liver Center and CLRI have become one of the busiest and most successful liver centers in the Los Angeles area. In addition to overseeing both his clinical and research institute, Dr. Mena is a tireless advocate for the awareness of liver disease in the community. He coordinates awareness programs for the Latino and Asian communities that encourage the screening of liver disease, such as fatty liver disease, cirrhosis, HCC, and hepatitis C and B viruses. Over the past 20 years, Dr. Mena has had many rewarding experiences mentoring residents and medical doctors of all levels and providing opportunities for them to collaborate with him on various publications and research studies. In 2019, Dr. Mena was awarded the Hispanic Health Leadership Award by the National Hispanic Health Foundation in recognition of his strong leadership in the health community. In 2020, I was proud to present the Healthcare Visionary Award from American Liver Foundation to Dr. Mena. Also in 2020, Dr. Mena was awarded the Fellowship of the American Association of the Advancement of Liver Disease. Dr. Mena, welcome and thank you for your support and participation. I don't know if you remember that a few years ago, we held a walk in Santa Monica and you came with FibroScan and helped us screen patients. So a belated thank you, and we are ready now for your presentation.
Thank you for the very nice introduction, Farah. I hope everyone can hear me fine. Yes. Audio is good. Okay, great. That was a great introduction, and thank you, Farah. Why don't we get started and let's go over our presentation, and I will share my screen and let's get this ball rolling. So today I wanted to talk about one of the topics that I am so passionate about, which is fatty liver. And hopefully we can answer a few of these questions on what is fatty liver, how does it affect our communities, how do we screen and test for it, and possibly in the future, what treatments we have. In today's slide deck, hopefully we can talk about the impact of advanced fibrosis and NASH. How do we make the diagnosis and how do we manage our patients? So to begin, NASH or fatty liver is a broad spectrum of disease that can go from simple steatosis, which I like to call non-alcoholic fatty liver disease, which then progresses on to NASH, which is a pathologic diagnosis, which we'll get into in a bit. And then you can have fibrosis and scarring in the liver. And down on this picture, you can see what the scarring in the liver looks like. And you can see pictures of fat in the liver. And then eventually it can get to cirrhosis, which means hardening of the liver. What I think is also crucial for us to remember is that we can go in between stages. The issue is when you do get to cirrhosis, did we pass that point of no return? We certainly know that patients who have cirrhosis become at risk for liver cancer. So we want to screen our patients for liver cancer every 6 months. But the question that we're also trying to resolve is, can you have reversibility of disease when you have cirrhosis? Now, one of the questions we always get is, what does NASH mean? So how do we go from simple steatosis or simple fat in the liver to NASH? NASH, as of today, is a pathologic diagnosis, which means this diagnosis is made through liver biopsy. And we want to make that definition by looking at the amount of steatosis or fat in the liver, the amount of inflammation, and something called ballooning. So if you see this picture on the left, there's a sign or an example of what does inflammation inside the liver look like. You can see the little fat droplets inside the liver, and then ballooning or swelling of the hepatocytes. And of course, the stage of disease, which is fibrosis. And then eventually that leads to cirrhosis. Our concern is, and that's the slide on the right here, and we're going to do this again, is that when patients have fibrosis, it increases their risk of liver disease in the future. So areas that we want to focus on in particular are patients who have fibrosis. And we want to know who has fibrosis stage 2, 3, and 4. And some of the discussion today is going to lead up to how do we do that? Do we have to do a liver biopsy on everybody? Does everybody want a liver biopsy? And I guess if I pulled some of the patients that are on this call or some of the doctors that are on this call, who would actually want to undergo a liver biopsy? But I will say liver biopsy has always been the gold standard. And when I started my career 20 some odd years ago, I used to do my own liver biopsies. And that really was the best way for us to measure disease. In this slide, what we're trying to demonstrate is those patients who do not have fibrosis will have a good liver transplant-free life, will have a good survival benefit, while those who do have fibrosis with time can run into liver disease. So I think the message today is anything that we can do to prevent our patients from having fibrosis and get the reversibility of disease is what we want to focus on. And looking at these slides again, as you saw 2 slides previously, we see the risk of liver disease really increases when you have fibrosis 2, fibrosis stage 3, and then of course, cirrhosis. And one of the questions we had in the questions before this lecture is, what is our mortality rate when you do have NASH, NAFLD, and cirrhosis? And you can see that your mortality rate increases as your level of fibrosis increases. And those who have cirrhosis are going to be at the highest risk for developing liver disease. Now, my patients always ask me, Dr. Mena, how quickly am I going to jump from one stage, stage 1 to stage 2 to stage 3 and then to cirrhosis? We think that when you have fibrosis stage 3, you can develop cirrhosis within about 2.5 years. And about 1 in 5 patients are going to develop cirrhosis. So trying to prevent cirrhosis is a key focus of what we want to do, not only with lifestyle modifications, but I also want to emphasize the importance of doing research and doing clinical trials, because it's through clinical trials that we, in medicine and in patient care, get better. So I really want to stress the importance of considering a clinical trial, enrolling in a clinical trial if you meet these certain inclusion criteria for this. Now, NASH is skyrocketing. This is going to be our biggest liver disease in our generation or my generation. When I started my career, it was hepatitis C. We did great with our research in hepatitis C and have excellent medication to cure patients of hepatitis C. Now the biggest issue that we're facing is fatty liver. And NASH is the fastest growing indication for liver transplant. Right now, it's the #2 cause of liver transplant overall, but it's the #1 cause of liver transplant, especially in women. The cost burden of these patients who have cirrhosis is looking to be about $1.4 million per patient. So this is a huge need that we need to address, not only in liver disease, but in medicine in general. And as you can see, the annual cost, especially in those patients who have cirrhosis, continues to skyrocket. And it's estimated that there's about 8.3 billion in medical costs that it takes to handle and take care of these patients who have cirrhosis. So the part that I think we want to emphasize is really want to stress upon identifying which patients are going to those that have fibrosis. We saw in a few slides earlier that those patients who have fibrosis are going to be at the largest risk for liver disease mortality. So we want to find ways on how to identify those patients who have fibrosis stage 2, fibrosis stage 3, and of course our patients with cirrhosis. And all of our future work and effort needs to be looking at how do we get the reversibility of disease? How do we educate our communities to do better, not only from a weight loss point of view, a nutritional point of view? What can we do, especially as physicians and as hepatologists, to make our communities safer and better? And I think that's our goal, especially of today, is to increase our awareness in cirrhosis, simple steatosis, and NASH and cirrhosis. So let's see on how do we make the diagnosis of NASH, NAFLD, and liver disease. First, we typically start off by abnormal liver enzymes. So when you go see your primary care doctor or a physician, they order blood tests. They're looking at tests that look at any evidence of liver injury. Those markers are usually in the form of what we call an AST and an ALT. And those tell us that, hey, something is kind of hurting the liver, something is bruising the liver. We should take it a step further. Usually then what we do is get an ultrasound. And what we're looking on the ultrasound is we're trying to see if there's any evidence of fat in the liver. They're trying to see if there's any evidence of liver thickness, which they call echogenicity. And of course, if there's any evidence of cirrhosis, which they describe as a nodular liver. It's always important for us to remember other forms of liver disease, in particular alcohol, getting a good history on alcoholic liver disease. Because of the pandemic, I have not seen this much alcoholic liver disease in my entire career than we had during the pandemic and post-pandemic. So getting a good history is important. Screening for hepatitis B, hepatitis C, autoimmune disorders, iron overload such as hemochromatosis is important. And when you look at what percentage of patients have liver disease, what is the most common types of liver disease? Fatty liver for sure is about 50% of cases now of liver disease. Alcohol, it's about 14%. Hepatitis Hep B, Hep C, and autoimmune disease is about 20%. So fatty liver disease is now our #1 cause of liver disease. But remember, this is a diagnosis of exclusion. So we must make sure that we're excluding other causes of liver disease. And that's important for us to remember. We like to call fatty liver disease or NASH almost as the metabolic syndrome. There's even a movement to change the name to metabolic associated liver disease because it's highly associated with components of a metabolic syndrome. 71% of these patients will have the metabolic syndrome, which includes hypertension. And about 66% of patients with NASH have hypertension. 83% will have some form of dyslipidemia, which means an elevated total cholesterol, an elevated triglyceride, which is the amount of fat your liver produces, and a low good cholesterol. 80% of these patients will have obesity, which is a BMI of over 30. And 54% will have diabetes. So knowing the presence of fibrosis in these patients is going to be crucial, not so much only in just cirrhosis, but fibrosis 2 and 3. And I keep stressing that part because that's the part that's kind of really separating simple steatosis or non-alcoholic fatty liver disease from non-alcoholic steatohepatitis or NASH. Now, how do we typically do this? Well, in the old days, it was liver biopsy, and liver biopsy is what I started my career, and that's how we we judged patients' liver disease. Of course, not everybody's going to want to have a liver biopsy. It's going to be tough to, some of the numbers that Farah was giving us earlier, 22 million Americans may have NASH. It's tough to biopsy all 22 million patients. So looking for other alternatives, which we'll talk about today, is important for us. But I still do believe in liver biopsy. Certainly, it's an invasive procedure. Certainly, it's not only the procedure itself, but it's the pathologist and his level of expertise in understanding NASH that's important as well. So taking all those factors into account helps me guide my decision on who do I biopsy, who do I not biopsy. Most of the biopsies that I do in my practice today are really more geared for clinical trials because we want to involve patients in clinical trials. But what the future of liver disease is going to is what we call NITs, which is non-invasive tests. So a non-liver biopsy way to help us judge the severity of liver disease. And we're getting better at this every day. And we're going to go over a few of these. But I think the key thing for us is, what are these tests? Are they reliable? How am I going to use these in my practice? And more importantly, how can I follow my patients? So if my patient has simple steatosis today, how do I make sure he's not progressing onto fibrosis stage 2, fibrosis stage 3, and onto cirrhosis? Non-invasive testing, NITs, is what's recommended by our societies. The Society of Liver Disease and the Gastro International Society are all recommending the use of NITs. And it's pretty neat on what we have now these days. It can go from simple blood tests. My favorite one is the FIB-4. I love the FIB-4 because it's easy for me to use. I can calculate it on a calculator, and it helps me get to what I need to do. The FibroSure is a blood test that we can order. Both LabCorp and Quest have it. The ELF, or Enhanced Liver Fibrosis Score, is also a blood test that we can use, but we typically use it more in clinical trials than we do in clinical practice. My one favorite of all, which I have a couple machines in my office, is transient elastography, or the FibroScan. I use this most in my office. I think it's a good guide to help me judge the level of fibrosis and steatosis in my patients. MREs is another good tool, but MREs we typically more use in a clinical trial setting. So what is a FibroScan? A FibroScan is a pretty neat device. It's kind of like an ultrasound, but different. And what we do is we put these probes over the liver, and there's a wave that goes through the liver, and the wave that comes back, we measure that wave. And within 15 minutes or so, or even less than that, we are able to determine the level of fibrosis and the level of fat in the liver without the need to use a liver biopsy. And it's a pretty good tool. We do about 8 to 10 every day in my office to help guide us as to what stage of liver disease the patient has. And you get a score, which we call a kilopascal. If your kilopascal is usually below 8, tells you that the patient pretty much does not have any evidence of fibrosis. When they're above 10-ish, that's telling us, hey, this patient does have some evidence of fibrosis. There is this intermediate range between maybe 8 and 10 that that patient may have fibrosis. I usually like to use that in combination with the blood test. But it's a good tool to help me in assessing liver disease that I don't have to do an invasive procedure such as a liver biopsy. The FIB-4 is my favorite. You can get this on the MedCalc. It's just a mathematical formula involving the patient's age, their AST level, ALT level, and their platelet count. And it also, like the FibroScan, gives me a score. If it's above 2.6, patient definitely has some evidence of fibrosis. If they're below 1.3, you're probably good. Patient doesn't have anything going on. You can bring them back in a year. That intermediate range is where I like to use the combination with the FibroScan. Kind of helps guide me if this patient does have any evidence of fibrosis. FibroSure is a blood test similar to the FibroScan and the FIB-4. There's a certain range that we can use. Also a good guide to tell me where this patient is lying. MRE is an MRI machine that tells me the elastography or the amount of fibrosis the patient has. Good tool, but we mostly use it for research purposes. Hard to get in clinical practice, but you can do it. Our MRI center here has the capability of doing it. So if you have that ability to use it, I do recommend it. It's sometimes not covered by insurance plans, so you have to be aware of that. This slide is a slide that we put on there, not because I'm going to go through a lot of statistics, because nobody wants to be sitting in a statistics class on a Wednesday afternoon. But what this tells us is it puts every single test together with a sensitivity and a specificity cutoff, so you can have a little bit of confidence depending on what range you have, how good a test is. I personally like to use two tests together. I usually combine the FIB-4 with my FibroScan to help guide me if that patient has fibrosis. And if that patient has evidence of fibrosis, I always try to recommend clinical trials. So what we're kind of going at here is that we have different levels of ways to assess our patients, depending on what you have in your clinic or at your disposal. All these tools are to help guide you identify those patients who have fibrosis stage 2, 3, and 4 and differentiate those from simple steatosis. Why is that important? Because I think it's important on how often are you going to see this patient? Is it going to be once a year? Is it going to be every 6 months? And you got to risk stratify your patients, especially if they have evidence of cirrhosis. I like this little algorithm. And, you know, when I speak, I also speak to a lot of FQHC clinics that have a lot of patients who are Latino with diabetes, obesity, and they're wondering, hey, Ed, who do I send my patients to? And it's easy to start off with a simple blood test, such as a FIB-4. And if your FIB-4 is elevated, let's say greater than 1.3, that's maybe somebody you want to consider to do a second form of testing. And the second form of testing I would consider is a FibroScan. And if the patient has a high FIB-4 or an abnormal FibroScan or has any evidence of fibrosis or cirrhosis, those are ones that you want to think of for clinical options, meaning refer to a specialist, such as on this call, Dr. Choi or Dr. Ayub, or to a clinical trial setting. If there's no evidence of advanced fibrosis, then I think that's a patient that you want to really see maybe once a year, stress lifestyle modifications, etc. If they're in this in-between phase, then we have to use our clinical expertise on what we want to do for these patients. We're going to talk about management in a second, but the most important management that we have is try to do diet and exercise. So let's go over an example of a case. This over here. So this is a case of a patient that we typically see in our clinic. This is John. John is about 63 years old. He had some blood tests done by his primary care provider. His AST was 78, his ALT was 83, his albumin 3.N, and his platelet count 190,000. He has a BMI of over 32, so that's obesity. He has hypertension, diabetes. He doesn't drink every day, but he does drink on a weekly basis. You screened him for hepatitis B and C, autoimmune disease, and all of that was negative. So based on this alone, what can we do to stage his disease? And as I mentioned earlier, I still love the FIB-4, so I would FIB-4 this patient. I have his age, I have his AST, I have his ALT, and I have his platelets. So his FIB-4 comes out at 2.84, so that's telling us, hey, he's got some evidence of fibrosis. This patient should do something to try to get his liver disease better. Maybe refer him to a hepatologist, maybe refer him for a FibroScan, or consider a clinical trial in this patient. What I think we want to show here is that these non-invasive tests are good ways for us to stage our patients with liver disease, and following them along either with a FibroScan or FIB-4 on a yearly basis, or what you feel is important, that is a good way so you can kind of see where your patient is going, because we want to be proactive and try to prevent disease, try to get them out of that F2, F3 range. So halting liver disease is what we want to do. Trying to cause the reversibility of disease is what we want to do. And anything and everything we can do to prevent progression onto cirrhosis, I think, is crucial. So then now you're going to ask me, well, doc, what are we going to do? Well, what do we have right now? I think the most important thing is still diet and exercise, lifestyle modifications. And, you know, when I sit with my patients, I try to be honest with them and say, tell me what you're eating. Usually you get the, hi, Dr. Mena, all I have is a little piece of chicken, a little salad. That's all I eat all day. And then when you try to probe them a little more, then they're drinking 12 sodas a day. They're having 24 tortillas a day. And it's trying to change those lifestyle modifications that I think is important to communicate with our patients. And I also can't stress the importance of exercise and having patients simply just walk 3 times a week for 30 minutes makes a difference. There are some non-indicated treatments for fatty liver, which you've probably seen, vitamin E and pioglitazone. I think the data on these are, in my opinion, limited, and it's something a physician would need to discuss with their patients before considering this. But at the end of the day, we have an urgent need. There's an urgent call on what we can offer these patients and what are we going to do in the future. And we'll get to that in a couple of slides. But for now, I want us to remember that having fibrosis does cause liver-related morbidity and mortality. You can progress onto cirrhosis in about 2.5 years if you have fibrosis stage 3. And fibrosis stage is associated with overall survival and liver-related complications. The liver biopsy is always our gold standard. And remember, the definition of NASH is a pathologic diagnosis defined by ballooning, inflammation, fibrosis, and steatosis. We're not going to biopsy all 22 million Americans or 80 million Americans with fatty liver disease. And the use of non-invasive testing, such as a FIB-4 and a FibroScan, is of value to look at disease progression. And hopefully with time, we'll have management options, but lifestyle modifications, diet and exercise is the way to treat these patients. I really want to stress the importance of clinical trials. And right now we have about 10 ongoing active clinical trials looking at drugs that target different parts of the liver, target different areas to look at insulin resistance, to look at oxidative stress, to look at inflammation in the liver, and more importantly, to look at fibrosis and cause the reversibility of disease. Some of the drugs that I think are close or are hot topics are Galectin's drug balaceptin. Semaglutide is the hottest drug right now in LA, as you can probably already have heard. Ocaliva may or may not get FDA approval. And also the sponsors of today is Madrigal and their drug resmetirom. I always can't pronounce these drugs. They're always make them so complicated. But these drugs are future potentials, and clinical trials is what we're looking at. So if you have the ability for clinical trials or enroll patients in clinical trials, I highly encourage that, because that is how we learn disease state. That is how we learn mechanism of action. That is how we learn efficacy and safety. I think that is the last slide, and I think I did this in just 20 minutes. So Farah, if I'm correct, now is our part for our question and answer session.
Yes, thank you so much, Dr. Mena. Fantastic, fantastic preview and information that you gave us. Let's see. I don't know if my camera is on. Okay, let's start. But now we are going to start the second half of the webinar. We made some changes to the way we run these webinars because our doctors, other medical advisory council members, and liver patients had recommended them. In this part, Dr. Mena will host a roundtable discussion with our guest experts who will talk about NAFLD and NASH while responding to your questions. Please remember you can enter your questions or comments on the chat function or Q&A tab, and our presenters will try to catch them all. So for this part, you've already met Dr. Mena, and I will introduce our two other experts. I am honored to introduce Dr. Walid Ayub, Professor of Medicine at Cedars-Sinai. I'm losing my contact. I don't know why. Let's start from Dr. Ayub is Professor of Medicine at Cedars-Sinai Medical Center and UCLA. He's the Associate Medical Director of the Liver Transplant Program at Cedars-Sinai. Dr. Ayub achieved his medical degree at the Creighton University School of Medicine in Omaha in 1999 before taking residency at UCLA West Los Angeles Veteran Administration Hospital. Between 2002 and 2006, Dr. Ayub conducted fellowships in hepatology and gastroenterology at Cedars-Sinai and UCLA, respectively. He then became clinical assistant professor of medicine at Stanford University and remained there until 2012, when he assumed his current position at Cedars-Sinai. Dr. Ayub is board certified in internal medicine, gastroenterology, and transplant hepatology. He has been involved in several clinical trials investigating pharmacological therapies for liver impairments, cholestatic liver disease, and viral and cholestatic hepatitis. He is currently a primary investigator for clinical trials assessing the efficacy of novel agents in the treatment of chronic hepatitis B and primary biliary cholangitis, PBC, and primary sclerosing cholangitis, PSC. He is a member of the PSC-CALID Consortium, Clinical Outcomes of Primary Sclerosing Cholangitis in North America. He serves as a primary investigator on NIH NCI-sponsored trials addressing the chemoprevention role of statin on hepatocellular carcinoma. Dr. Ayub has been invited to speaker at the digestive disease meetings and has moderated sessions at American Association for the Study of Liver Disease, including and discussing liver cancer. He has addressed treatments of viral hepatitis at the American Transplant Congress and has delivered presentation on discussing quality of organs in the solid organ transplant recipient. Dr. Ayub served as a member of the Hepatology Associate Committee of the American Association for the Study of Liver Diseases, known as AASLD. He is a fellow at AASLD and a member of the American Gastroenterological Society, American College of Gastroenterology, and American Society of Transplantation. He has held responsibilities as editor of Journal of Pancreatic Disorders and Therapy and a reviewer for a variety of journals such as the American Journal of Transplantation, Liver Transplantation, Journal of Clinical Gastroenterology, and Digestive Diseases and Sciences. Dr. Ayub's specialties are vast, include hepatology, hepatitis B, C, and D, primary biliary cholangitis, primary sclerosing cholangitis, PSC, autoimmune hepatitis, cirrhosis, portal hypertension, end-stage liver disease, acute liver failure, liver cancer, liver transplantation, and of course, fatty liver disease, NAFLD and NASH. Dr. Ayub, welcome back. We appreciate your support Thank you for bringing your vast knowledge and experience to us.
Thank
And
you
now,
for this nice introduction.
thank you. And now it's my pleasure to introduce Dr. Gina Choi, Associate Professor of Medicine and Surgery, University of California, Los Angeles, lovingly known as UCLA. Dr. Gina Choi graduated from Stanford University and subsequently spent 1 year in Korea as Fulbright Scholar. She earned her medical degree at the University of California, San Francisco, and completed her internal medicine residency at New York University. She then continued her training and education by a gastroenterology fellowship at UCLA and pursued an additional year of advanced training in transplant hepatology at the University of Pennsylvania. Dr. Choi has received numerous teaching awards and is the Associate Program Director of the Transplant Hepatology Fellowship Program. She focuses on treating patients with the complications of cirrhosis and manage their evaluation and care before and after transplant. Dr. Choi is well-versed in the newest approach to treat viral hepatitis and fatty liver. She is part of multidisciplinary team employing the latest treatments of liver cancer. She is also interested in autoimmune liver disease, including autoimmune hepatitis and primary biliary cholangitis, and in caring for women with liver disease. Dr. Choi is board certified in internal medicine, gastroenterology, and transplant hepatology. Dr. Choi, welcome to our webinar. This is, I believe, your first session, so it's your inaugural webinar. Welcome.
It is. Thank you so much I don't think I look like this picture anymore. I think I need a new photo.
Yes, I think we need to get a new picture from you.
Thank you. Happy to be here.
Thank you for coming. Dr. Mena, will you please start the roundtable?
Sure. So we have some questions that have been typed in already, but I think one question that I'd like to throw out to either one of you is, what about ethnicity and genetics? Is that playing a role in fatty liver disease? Do you see a certain ethnic group more common in your practice? And when it comes to liver transplant, is there one ethnic group that has more liver transplants because of fatty liver than others? Gina, you're nodding your head, so you wanna go first?
Yeah, sure. First, I'd like to thank Ed for that, Dr. Mena, for that wonderful introduction. I was like taking pictures of your slides while you were giving them. Okay, so this is an interesting question. You know, I think that there have been certain gene associations, with certain ethnic groups. So for example, PNPL3, this is very scientific, has been shown to have an increased risk of NAFLD. And we often see that in patients who are Indigenous Americans or who are Latinos. I think Dr. Mena has he's committed a lot of his time and energy to the Latino population. So I think he's actually the best person to answer this question. But, we certainly do see disparities in transplant, both in outcomes and people who get transplanted. So we know that women get transplanted less than men. And we do know that some ethnic populations like African Americans, for example, do get transplanted less. Does Dr. Ayub or Dr. Mena want to add anything to that?
Yeah, I mean, you got it, Gina. The PNPLA3, is the most popular or most famous risk, for fatty liver. It's mainly found in all population, but in higher prevalence in Hispanic. But it's also found in other ethnicity. While this variant is found in Hispanic, there are other variants found in Caucasian. So there's one common in people of European descent, PM6SF2, for example. And what's interesting about all these variants, there's a lot of research going on showing a predisposition to more advanced disease or protection against progression of certain certain complication from fatty liver and non-alcoholic steatohepatitis. So I think this is kind of part of precision medicine of the future, where we're going to have tailored therapy depending on genetic profile for each patient.
Yeah, but I think in routine clinical practice, we don't really test for these genes. You know, they've been identified in the scientific bench, but we don't check it in clinic or anything.
Yeah, they're not ready for prime time yet, but I think down the line, you know, they will see the light into clinical practice.
Yeah.
Yeah, no, I agree 100% that most of our Latino patients are going to be with that gene BMPLA3, and there's some other genes that are also looking at to see where their role is in fatty liver disease and advancement onto cirrhosis and fibrosis. So I think it's an interesting time for us to learn about how genetics play a role. But aside from genetics, what about diet? Is there a specific diet that you think is going to be useful in patients with fatty liver disease? Is it just the American diet, or what I call the NFL diet, burgers, fries, pizza, you know, everything that we eat on Super Bowl Sunday? Is it that what's hurting us the most, or what do you guys think of the American diet or diets in general?
Yeah, I mean, that's a great question. Sorry, Ayub, I'm going to go first. So people often ask me, you know, like what kind of diet? Because I think diet is important. You know, I think we're learning more and more about the microbiome, and that's greatly impacted by that, how that relates to disease, and what we put in our mouth totally affects the microbiome. I think but I always say the first absolute no-no is alcohol. Like if there's one thing you're going to eliminate from your diet, it has to be alcohol, because, you know, alcohol and fat have the exact same effect on your liver. So if your liver closes its eyes and there's fat on the liver can't tell if it's from being overweight or if it's being from the alcohol, right? I think that in terms of dietary intake, you know, I think the good diets we talk about, low carb, low fat, Mediterranean diet, and the bad stuff is what Dr. Mena talked about, the NFL diet, you know, saturated fat, sweetened beverages, refined carbs, excess calories, and I think portion too. So I think that those are all like the dietary recommendations that I give to my patients. Waleed, what do you think?
You know, I tell any diet is a good diet as long as you're willing to stick to it for a long time. That, you know, make it simple. And, you know, we're human, you know, we like to eat, and food temptation is always there. But, you know, if you have to choose one diet, the most studied diet is a Mediterranean diet. And, you know, that's, you know, rich in omega-3, low carb, you know, monounsaturated fat. So that would be the diet that has the most data scientifically on the impact on fatty liver. But in real life, you know, people who are able to adhere to certain lifestyle restriction in their diet, that will be the best diet to do. And, you know, one more thing to add to the diet. Diet by itself is good, but if you couple it with exercise, this is where you get the most benefit in terms of, you know, fatty liver management.
Right. And I think a good place to start is, I always say, my 50% rule. You know, like if you told me I could never eat bread again, I just wouldn't make it, you know. So I tell patients, you know, rather than having 2 scoops of rice, have 1. Rather than having 4 tortillas, have 2. And I think these are kind of modifiable things that make a big difference over time.
And I also tell them, you know, actually I draw a plate for them, and, you know, it's very simple. Half of it should be green vegetables, quarter should be protein, and fish, preferably the omega-3 fatty acid. And the last quarter is what I call the forbidden food, the carbs. So you choose what you want in that quarter of your plate: bread, rice, pasta. You make the decision. And if you stick to that regimen, then you'll get the most benefit.
Also the size of the plate, right? Well, you don't want the plate to be this big, you know, maybe this big.
That's pretty sneaky. I know.
Well, if they're starting with a large plate, they can use the same plate to cut down portion size.
Right.
And eventually the plate will shrink.
Dr. Mena, while we are talking about how to nourish our body, we have a question that asks, can mindfulness meditation be helpful in lowering high blood pressure in people at risk for NASH?
So basically, Can meditation help you, especially if you have hypertension? I say the answer is yes. Any type of holistic approach to your body, whether it's going to calm you down and help bring down your blood pressure, I think is a good thing. So I hope that answered that. Now, what about, we talk about, especially in these clinical trials, the reversibility of disease. Do you guys believe we can have the reversibility of disease? Can you go from NAFLD to NASH? Can you have cirrhosis? Can you have reversibility of cirrhosis? What do you guys think? Can I get patients off a transplant list if they do the right things? What do you guys think about that?
I feel bad. I'm always going first. Doctor, you want to go first on this one?
All right, I will go first. It depends where they are, where the patient is in the natural history of fatty liver. If somebody hasn't reached, for example, F3 yet or F4, then reversibility is more likely in those patients than in patients who are already in stage 4 or have cirrhosis. Now, that's not to say that's not possible. As you know, there have been few studies from the United States and Europe. They look at bariatric surgery, people who went for a surgical procedure to lose weight. And they did liver biopsies before and after the surgery, 1 year or 18 months later, or even 3 years. And what they found, there was a good portion, I think about 80% of the patients were able to reverse some of the scar tissue. And some people actually went from a lot of fibrosis to very little or no fibrosis. So it's a small study in a way, but at least it sheds a light that there is hope to reversal of fibrosis.
Yeah, I think that, once you hit, we talk about fibrosis, cirrhosis, they rhyme, but they're totally different things, right? So if you have stage 1, just like Dr. Mana's picture showed, there's stage 1, 2, 3, 4 fibrosis, and stage 4 fibrosis equals cirrhosis. I think when you get to cirrhosis, when you hit to 4, it's hard to go back to 3 to 2 to 1. But I think if you're at 3, you can certainly go to 2, and you can even go to 1, depending upon if you modify the risk factors. However, just because you're at 4 doesn't mean it's a death sentence, because once you hit 4, then it goes to symptoms or no symptoms. And for people, you may be able to stay in the no symptom box forever. If you modify your risk factors, meaning lose weight, avoid alcohol, etc. So I think that it's very important to follow with your doctor, but not everybody goes to transplant or needs a transplant.
And Ed, one more, I don't want to have the audience be pessimistic about fatty liver. Not everybody with fatty liver will develop cirrhosis. So that's very important.
Good point.
Only 25% of the people with simple fat, those will be the people you showed in your graph all to the left, will progress to steatohepatitis or the bad form of fatty liver. And of those, 25% will progress to cirrhosis eventually.
So that I once told my patient, 1 in 4 with fatty liver will go to hepatitis. 1 in 4 will go from hepatitis to cirrhosis. So then my patient said, "Oh, does that mean that there's a 3 in 4 chance that I'll stay right where I am?" And I'm like, actually, yeah, if you do the math, that's true. Right.
So that's very important to explain to the patient, because fatty liver is so much in the news now that it's not a death sentence, actually.
Right. Good point.
You have 75% chance of staying where you're at.
And how are you guys following your patients in your clinical practice? Both of you are at transplant centers. Are you biopsying every year? Are you using NITs? How do you manage your patients with fatty liver?
Should I go first, Gina?
Yeah, sure. Your turn.
All right. I'm a big believer in non-invasive testing. At Cedars, we're privileged. We have a MRI elastography machine. And the difference between MRI elastography and a FibroScan or ultrasound elastography, think about it. The FibroScan looks at 1 square of your liver, 1 tiny square, while the MRI elastography look at the whole liver together and give you an average score, how much scar tissue or fibrosis the liver has, in addition to the fat content and sometimes inflammation if you have the right software. So I start with I look at the lab. The FIB-4 is very easy to calculate, and every EMR or electronic medical system has it now as part of it. If not, you use your calculator. You get in a score, and then I usually confirm it with a FibroScan or an MRE at that time, depending on the patient body habitus. It's also important to know the limitation of these tests. We could do FibroScan on everybody, but for example, if somebody has heart failure history or controlled heart failure, or if they have a lot of inflammations, they just had an infection, hepatitis A, for example, food poisoning. And if we do FibroScan on these patients, their liver is going to look very sick, which is not true because this is a transient or a reaction to liver congestion, for example. That's why using more than one modality is helpful in sorting out that problem sometimes.
Yeah. So, for example, I think if someone makes it to Dr. Mena, me, or Dr. Ayub, somebody's out there is worried, right? So then I first asked myself, we talked about how there's all these different stages. So I first think about myself, okay, what bucket am I going to put my patient in? Is it the worried bucket or the not worried bucket? And I figure if they're in the worried bucket or not by first doing that simple blood test that Dr. Mena talked about, the FIB-4, right? Just a quick little calculator. And then if that's elevated, then I go move forward to the next step, which is the FibroScan machine. And so that's kind of how. And then for people who have advanced cirrhosis or advanced fibrosis, then I start thinking about, I got to get really aggressive. I can't just say, oh, lose weight, see you in a year, right? I got to be like, okay, what are you eating? Have you gone to the dietitian? Should we start thinking about medical therapies, medicines, things like that? And then that's how kind of I approach it.
That's great. Now, but biopsies, do you feel a need to still do biopsies, or is it only for clinical trials? Where do you see the role of liver biopsies?
Ooh, juicy question. Dr. Ayub, I want you to go first.
I haven't done a liver biopsy on a patient with fatty liver outside of clinical trial. I think our technology, the technology we have, and with a good clinical judgment, you could get information you need. The only time I would consider it if I'm considering other disease besides fatty liver occurring with fatty liver. That would be the only exception.
Yeah, that's a great point. So I used to be very into biopsies. I don't order them for fatty liver anymore because we're so much better at prognosticating with non-invasive tests. But, sometimes, especially women come in with a mixed picture where it could be fatty liver or it could be an autoimmune hepatitis, in which that case I do the biopsy, like Dr. Ayub said, it's like the deal breaker. It's like no confusion.
Excellent point. Excellent point. Now, we've got a message in the chat that says, my stomach is swollen, and is it time to do a paracentesis? And I think one thing I forgot to mention in my slide deck is, what are the signs and symptoms of fatty liver and then cirrhosis? And I like how your example was, Gina, on the cirrhosis. You had the two fingers, no symptoms or symptoms. How do you break down the no symptoms and symptoms of liver disease or fatty liver cirrhosis?
Right. So when you have cirrhosis, it's symptoms or no symptoms, decompensated or compensated. So once you develop symptoms, that's when we start talking about liver transplant, right? And those 4 symptoms are ascites or water in your belly from the liver, liver confusion, varices in your esophagus, and liver cancer. So if you have any of those 4 things, you're considered decompensated, right? And so in NAFLD, you shouldn't have water in your belly unless you have cirrhosis, right? And so you got to first make sure, where's the water coming from? Is it really your liver? Are you sure it's not coming from your heart or from your kidney, who are the other 2 potential culprits? I think it's really hard because, is it NAFLD in and of itself should not cause water in your belly. Does that make sense? Like, you want to elaborate on that, Dr. Mena? It kind of makes sense, right?
Yeah, no, it makes perfect sense. You
Yeah.
explained it well. And, the difference between NAFLD, NASH, and cirrhosis is when you have cirrhosis that you have the decompensated liver disease.
Right.
Waleed, anything you want to add on that?
No, I think it's two different stages of disease. If you have NAFLD without the cirrhosis, you should not have water in your abdomen. You might have bloating that causing abdominal distension, but that's a different etiology than the symptoms of NAFLD.
Now, I think we're getting close to the end, but one question that we haven't talked about yet is, but there was a few questions on the patient question is, patients who may not be obese or have diabetes, we call it lean or lean NAFLD. Are you seeing that in your practice? What are you doing for them? Since you can't tell them really to do the lifestyle changes, do you do a biopsy on all your lean fatty liver? What do you do in lean fatty liver?
Right. So that is 100p, totally correct. I think that there are the first question we started with, are there ethnic differences in NAFLD? And there are. So we see that people with lean NASH or who have fatty liver on their liver, but nowhere else on their body, low BMI, we often see that among Asian people from China, Japan, and also among the Asian subcontinent, Indian people, right? So they tend to have lean NASH. And it's hard to tell them, hey, lose weight, because there's no weight to lose. So Dr. Ayub already mentioned exercise. So if you exercise, even if you don't lose weight, studies have shown that your AST and your ALT, which are your liver tests, which indicate inflammation, improve. So I tell those guys, you should be, like Dr. Mena said, walking 3 times a week, 30 minutes, and you can see an improvement. Also, we fixate on weight, but really what these people really get caught, what really gets them in the end is the metabolic complications. So even though you have lean NASH, a lot of these patients still have diabetes, high blood pressure, high cholesterol. So you got to make sure the A1C is 7, you got less than 7. You got to make sure the blood pressure is less than 120/80. Got to make sure that the lipids are controlled. So, I think weight loss is an important part, but there are other things that you can focus on.
I think that's a very important point, Gina. So patient with lean NAFLD have a 3-fold higher rate of developing diabetes with time. Very important. And we know diabetes is one of the biggest risk factor for moving from simple fat to inflamed fat or steatohepatitis. So those lean NAFLD are very at risk for developing diabetes. And the other complications they get is cardiovascular disease. So they have a 2-fold increase of cardiovascular disease, similar to the patient that are obese and have NAFLD. The other important point to make, we use different parameter for obesity for Asian, for example, versus Caucasian. So for Caucasian, a BMI over 25 is overweight. For Asian, BMI over 25 is obese. And this is where actually the weight loss is actually could help. And there have been studies that showed people who lose 7 to 10% of their body weight with exercise are able to improve that quote unquote the lean NAFLD disease they have and lowers the risk of cardiovascular disease and diabetes. So for me, even if a person has a normal BMI, I still ask them lose 5-7% of your body weight if you can, as long as their BMI over 20. That's what I usually draw the line.
Great. I think that's all the questions I have on my list. Farah, is there any other questions that we haven't addressed or issues that we haven't addressed?
No, the questions that were in Q&A you answered, but you said something, I don't remember which one of you said something about women. You mentioned specifically women and NASH. Is there a difference between men having NASH and women having NASH? The women get that more than men? I'm just kind of confused to see what's the difference between them.
I made a comment earlier that studies have shown that women get transplanted less regardless of the etiology, whether it's NASH or alcohol or what have you. In terms of NAFLD, I think it's pretty men and women 50-50.
It's 50-50.
Yeah, in terms of just epidemiologically, as opposed to autoimmune liver disease where, for example, it's more women than men.
That's great. Thank you so much.
Sure.
this was a fantastic roundtable. I really wish we could just continue this talk because your conversation is just fascinating, full of information. Thank you so much. I want to thank, of course, Dr. Mena for hosting the program and for your excellent presentation. Thank you. And thank you, Dr. Ayub. We appreciate your continued support of our efforts. We've been together doing this for a long time, Dr. Ayub. So I really appreciate that you are still with us and doing these things. And Dr. Choi, welcome again. I am so happy we finally could come up with a day and a time that you could be with us. Thank you so much. And all of you, your information and the way you talked about the disease was, while it was very informative, it wasn't too difficult for those who are not in medical business to understand. So I really appreciate that. Thank you.
Sure. Thank you so much for inviting us.
Of course, this is.
Thank you.
Thank you so much. We record that, as we mentioned, and there were over 50 people who had signed up that wanted to be in this program that couldn't, a lot of them didn't make it. But we will announce the recording. We'll put it on our website so people can actually enjoy seeing that and know who you are and all that. So we will do that as soon as Lori can finish up her work on the video. Now I have just a couple of little ads for our Liver Health Foundation. I forgot to thank our, of course, our sponsor, Madrigal, and GLI, Global Liver Institute. Thank you for your support. We appreciate the funds that we receive so we are able to continue these free webinars and our other free events. So we are hosting a free in-person walk in Santa Monica on September 23rd from 8:30 a.m. to 12 noon. The chair of this walk is Dr. Nissen from Cedar Sinai. So please register to walk with us to support liver patients. It's a family and community-oriented event. We have food, we have face painting, music, balloon, you name it, we got it. To register, please visit our Walk for Your Liver LA site. And the biggest and the best party of the year, Salute to Excellence, is on October 21st in Hollywood. If you thought last year's event was great, I have to tell you, just wait to see what we have planned for this year. The seating is very limited, so please, you can email us at info@Liver Health Foundations, and we will reserve your seat for you. Then the last thing is Liver Health Foundation is on all social media. Please, I switched the order. In July, we will be doing a special webinar on transplantation. A part of the webinar is going to be on adult transplantation, and a second part will be on children that receive liver transplantation. We have quite few liver stars who are children who have received the transplantation, and we very much like to see how they are doing now, 3-4 years after transplantation. And the other, so please be on the lookout. I will send emails out about that. And then we are on all social media, Facebook and LinkedIn. Please find us and like us. We really want you to like us on these sites. That's about all I have to do. Thank you for to our sponsors, and a special thank you to all of our doctors. We really appreciate that you're donating your time and expertise and helping our patients. With that, good night, take care, be well.
Thanks, guys.
Thank you.
Good
Thank
evening.
you.
Thank you,
Bye,
Dr. Mann.
everyone.
Thank you.
Good
Thank you, Farah. Okay, bye.
Thank you, Farah.
Bye-bye.